Yeah, good evening, everyone. Today I'll be talking on three important organisms. One is regarding Mycoplasma species. Another one is Haemophilus ducreyi, which is responsible for Chancroid, which is a sexually transmitted disease. And one more thing is Herpes simplex virus 2, which is also another sexually transmitted disease. Among these three, Mycoplasma not only associated with the genitourinary tract infections and also causes for respiratory tract infections. So the main focus on Mycoplasma is related to the respiratory tract, including the genitourinary tract, and the other two are related to purely genitourinary tract infections. Case scenario related to the Mycoplasma, which is responsible for primary atypical pneumonia. See, a 29-year-old male patient was admitted in the hospital with fever, headache, non-productive cough, wheeze and sore throat since 10 days. Cough worsened day by day with shortness of breath, and bilateral basal crepitations were seen on chest examination. Peripheral smear examination shows agglutination of RBCs with leukocytosis, and hemoglobin was 6.3 grams per cent, and ESR raised, it's around 85 millimeters per hour, and chest X-ray suggests of patchy consolidation on lower lobe of the right lung. The treatment was given with azithromycin, and patient was recovered from the clinical condition. So this is the case scenario where you can see the peripheral smear, where you can see the agglutination of the RBCs with relative leukocytosis, and on the chest X-ray you can see the patchy consolidation of lower lobe, especially this lobe patchy consolidation you can see. So this is a case of atypical pneumonia or primary atypical pneumonia, and so the commonest organism responsible for this Mycoplasma pneumoniae, which are the smallest extracellular organisms which are lacking the cell wall, and so they will have the plasticity and assumes different shapes due to their plasticity, and sterols are present in their cell membrane, and they belongs to the family Mycoplasmatidae, and the two important genera from this Mycoplasmatidae family are Mycoplasma of genus and Ureaplasma genus. And here you can see the morphology of this bacteria, like due to the plasticity without having the cell wall, they assume different shape. This is one shape, this is another shape, and this is another shape. Different shapes are seen, and like multiple shapes including round, pear shaped, or even filamentous forms are seen. A species of medically important from this Mycoplasmatidae family, or especially from the genera Mycoplasma. One is Mycoplasma pneumoniae, which is also known as Eaton's agent because it was isolated by Monroe Eaton in 1944 and responsible for primary atypical pneumonia. We will learn about it in the future slides. And next organism is the Mycoplasma hominis, responsible for pyelonephritis, PID, postpartum fever, and infections among the newborns also. Next one is Mycoplasma genitalium, which is responsible for non-gonococcal urethritis. And next one is Ureaplasma parvum. That's the old name for this is Ureaplasma urelyticum. Again, one most important organism causing for non-gonococcal urethritis. And as far as the sensitivity of this organism is concerned, they are killed at 56 degrees centigrade within 30 minutes, and these organisms are sensitive to the cyclohexamide and also cetramide, and only the Mycoplasma pneumonia can grow in the presence of 0.002% of methylene blue, whereas other species of Mycoplasma can't grow in the presence of methylene blue. Then, what is the reservoir for these particular organisms? The main reservoir or source is the patient who is suffering the disease, and also they are present as commensals in the genital tract and also the respiratory tract, in the in the throat as commensals, and they act as source. And so the people who are stayed in the military bases, and the people who are there in the crowded classrooms, and also the boarding schools, children usually suffers with these infections, followed by the release of this bacteria from the reservoir or from the patient through the respiratory droplets. So these respiratory droplets, by means of inhalation, enters into the other individual and cause for the infection. Another mode of transmission is close contact with the infected individuals, either in the family, or sometimes what will happen is through the fomites also it can get transmitted from one person to other person. Remember, this is highly contagious organism causing for infections. And if you see the pathogenesis is non-invasive organism, it's extracellular organism. It's non-invasive and extracellular organism, but smallest organism. And it attaches the respiratory epithelium via the P1 protein, which is a very important surface protein. Through this, it can get attached to the respiratory epithelium and initiates the inflammatory process to produce the disease. Of extra what we call extra pulmonary manifestations. And next one is a protein A antigen. This protein A antigen binds to the host cell epithelial cells through the sialic acid residues and destroys those cells. Again, the antibodies are produced against this particular antigen, and these auto antibodies are toxic to the RBCs and results in hemolysis. And next important thing to remember is the microbial antigen themselves acts as super antigens, and because of this super antigenic nature, they produces lot of tumor necrosis factor alpha and interleukin 18 and interleukin 4, and all results in the activation of the B lymphocytes and also the neutrophils. And this super antigen to some extent clears the bacteria and also causes for disease manifestations. And cytotoxin from this bacteria, which is a component of the bacterial cell, is responsible for ADP ribosylation. This ADP ribosylation inhibits translation and also the cell differentiation. And next one is lipoproteins of this bacteria will initiate the strong inflammatory response in the infected individuals. Then if you see the pathogenesis, and this pathogenesis is a pathogenesis, the droplet, just keenly follow the path. Once the droplet infection occurs, they enter the respiratory tract and get attached to the respiratory epithelial cells. So this respiratory, once it's attached to respiratory epithelial cells, and the produces hydrogen peroxide and also the superoxide dismutase. And these hydrogen peroxide and superoxide dismutase are directly responsible for direct injury to the respiratory epithelium. This is respiratory epithelium. That's directly responsible for damage to respiratory epithelium. In other way, the lipoproteins of this bacterium and also the glycolipids of this bacterium will initiate the very strong inflammatory response and this strong inflammatory response is responsible for atypical pneumonia or primary atypical pneumonia, which is responsible for shortness of breath. This is one way of pathogenesis, and another way is once the bacteria gets attached to this epithelial cells, then the macrophages also gets activated. Once these macrophages get activated, they releases the interleukin 18, and this interleukin 18 is responsible for neutrophil activation and also the chemotaxis of the neutrophils, which again results in the strong inflammatory response. In other way, this interleukin 18 also activates the T lymphocytes, convert into T helper 1 type of cytokines released in the form of IL-2, and also that this is responsible for the differentiation of T lymphocytes into T helper 2 types of cells, which are responsible for the production of interleukin 4. So this interleukin 2 is responsible for differentiation of the macrophages, and interleukin 4 is responsible for the activation of the B lymphocytes to switch over to produce the concerned antibodies. And these B lymphocytes also activated polyclonally and causes for immune modulation, and this immune modulation results in the formation of autoantibodies, and these autoantibodies are responsible for varieties of central nervous system infections, skin infections, and hemolytic process. This is one way of pathogenesis, and another way of pathogenesis is this bacteria will enter from the respiratory epithelium, passively transformed into the circulation, and once it enters the blood, and in the blood they infect the epithelial cells of this endothelial cells of the blood vessels, and causes for the release of interleukin 8. Again, this interleukin 8 is responsible for the neutrophil chemotaxis, which results in inflammatory process. And in the blood vessels, again they are responsible for the production of tumor necrosis factor alpha and some of the complement related chemical mediators, and which results in vasculitis and also thrombosis. This vasculitis and thrombosis results in arthritis and skin rash and also the hemolysis. Like this, the Mycoplasma pneumoniae responsible for severe form of primary atypical pneumonia, and also responsible for the formation of autoantibodies and results in certain autoimmune related diseases, and also causes for the severe accumulation of the neutrophils in the blood vessels and causes for the vasculitis and thrombosis of the involved blood vessels of the organs. Then, related to the Mycoplasma pneumoniae disease, this disease is common in the summer and also in the fall season, and after an incubation period of 2 to 7 days, the people may suffer with walking or working pneumonia. So the people will have the signs and symptoms of pneumonia, but there won't be much productive cough. Only dry cough will be there, and a few people will have the fever and chills, wheeze and rales, and shortness of breath, especially while climbing the stairs, and so very severe tiredness will be there. Tiredness will be there in this particular case, and edematous pharyngitis without cervical lymphadenopathy is seen. This kind of primary atypical pneumonia is almost similar to the community acquired interstitial pneumonia produced by Chlamydia pneumoniae and Legionella pneumophila and viral pneumonia, like even COVID-19. COVID-19 also produces the same kind of interstitial pneumonia. That kind of pneumonia produced even by the Mycoplasma pneumonia too. Then what are the other manifestations of primary atypical pneumonia in the certain people? So it is very clinical manifestations are very severe among immunocompromised individuals and also the elderly people and young children less than 5 years age group, and also the people who are suffering with sickle cell anemia and Down syndrome. Among them, the disease is very severe in nature. And sometimes, as I mentioned already, the extra pulmonary manifestations also will be produced in the form of arthritis, hemolysis, skin rash, meningoencephalitis, and transverse myelitis, including Guillain-Barré syndrome. All are the extra pulmonary manifestations due to the autoantibody formation, which may result due to the immune modulation by the polyclonal activation of the B lymphocytes. Diagnosis: the tracheal washings and sputum has to be collected and it has to be transported through the SP4 transport medium if there is any delay, and then you have to do the microscopic examination by gram staining, and it's a poorly gram stain, but the better staining is gram, means the GMs are stain, where you can see the bacteria like this. Here the bacteria are seen here, very small bacteria which are present extracellularly, you can see. And the clinical diagnosis also very much indicative of this disease, and PCR and nucleic acid probes also useful, and the culture won't provide a timely report. It will take some 1 to 2 weeks to see the colonies, so culture is not that much easy. It will take a lot of time, so we won't depend on the culture for the diagnosis of this disease. And other serological tests like ELISA and immunofluorescence tests are available for the detection of antibodies, and they are sensitive and also specific in nature. Then cultural characteristics: these organisms are aerobes and they can grow better in PPLO broth, that is that consists of 20% horse serum and 10% yeast extract with the penicillin and thallium acetate as selective agent. They act as selective agent. And next one is the colonies will appear after 1 to 4 weeks, and usually 10 days minimum time is required. That's the reason why we won't much depend on the culture of the clinical specimen to diagnose this particular condition. On the culture media, the growth is seen in the form of fried egg colonies or mulberry colonies, and we can stain these colonies on the medium itself by using the Dane stain. This Dane stain is in a combination of methylene blue with azure 2 in the sodium carbonate solution, maltose and distilled water, and this is known as Dane stain. And if you pour this Dane stain on the colonies directly, they will show the colonies in the form of royal blue in the centrally and peripheral light blue with granularity. This kind of appearance. Here you can see, here the contrast of course not being maintained properly. Anyhow, the centrally royal blue color and peripheral light blue with granularity. Here you can see the granularity very typically, and here also you can see the granularity and the peripheral area of these colonies. Another important test is cold agglutinin test. Here we are going to detect the autoantibodies to the RBCs. Here what we have to do is, we have to take the patient serum, collect the patient serum, and then mix up with the 0.2% ORBCs, group O RBC suspension, and both this combination have to incubate at 4 degrees centigrade overnight. Then you have to look for clumping. And this clumping typically will get dissociated at 37 degrees centigrade. That's why they are known as cold agglutinins or cold antibodies. So this test is significant if the titer is 1 in 32 dilutions. And one more important point to remember is this test is not much specific and positive only in 65% of the cases. Remaining 35% of the cases, they may give false negative results. CT scan, you can see the lobar or segmental consolidation. See the here you can see the segmental consolidation here. This segmental consolidation or lobar consolidation you can see with paranpneumonic effusion. If you see here, but around the pneumonia, see here the pneumonia. Here you can see the effusion. Paranpneumonic effusion is seen mainly in children, and on chest X-ray, peribronchial pneumonia with thickened bronchial markings. See, these are bronchial markings are very much thickened. Bronchial markings. These are all the bronchial markings. Thickened bronchial markings are seen here with interstitial infiltrations. And if you see this biopsy, lung biopsy, you can see the infiltration of the cells. See here, these are violet colored cells are infiltrated cells, the inflammatory cells which are infiltrated interstitially. So in between the alveolar interstitium, the cells get infiltrated and responsible for obliteration of alveolar space, which results in asthmatic condition or shortness of breath. Epidemiologically, this is strict human pathogen and spread by close contact and commonly affects 5 to 10 years old children and represent to 20% of the community acquired pneumonias. It's a disease is very much uncommon among the infants. Okay, and then if you see the treatment, azithromycin or tetracycline or fluoroquinolones like levofloxacin or ciprofloxacin and ofloxacin, these are the drugs of choices. So any one of these things we can use, but no use at all with the cephalosporins and penicillins and vancomycin and bacitracin. The reason is these are all cell wall lacking organisms. So all these bacteria, cephalosporins, penicillins, vancomycin, bacitracin, acts on the cell wall, thereby they are responsible for killing of the bacterium. So since they are lacking the cell wall, these antibiotics have no use. Then we have to advise the patient to take lot of fluids and lot of rest to be taken, because to combat the shortness of breath. And prognosis, the spontaneous recovery is possible usually, but if you use the antibiotics, then the speedy recovery will be there, and cough and weakness may persist for the weeks even after recovery from the disease. Then preventive aspects, this sanitation, the strict hand washing is very important, and we have to advise the people to cover their mouth while sneezing and coughing. And remember, there is no vaccine is available, and certain antibiotics can be used for the prophylactic purpose, that's under the chemoprophylaxis, like tetracyclines or erythromycin or chloramphenicol can be used as prophylactic chemoprophylactic agents. Another important organism is Mycoplasma hominis. This Mycoplasma hominis mainly responsible for genitourinary tract infections and is a fast grower when compared to the Mycoplasma pneumoniae, and it produces large fried egg colonies are produced on the concerned medium, and the clinical presentation is seen in the form of puerperal sepsis and also especially in the form of acute salpingitis, pyelonephritis and pelvic inflammatory disease, which may result in sterility sometimes. And postpartum or post-abortal infections also possible, and they also produces primary atypical pneumonia among the newborns. If the babies are born to the infected mothers, while normal delivery the babies may get infected and results in primary atypical pneumonia. Remember, this colonizes 15% of the sexually active men, whereas 60 to 80% of the sexually active women. So the main source for this infection always is sexually active women. And next one is ureaplasma parvum. It's also the previous name or old name for this is urealyticum, and this is urogenital pathogen, and it affects mostly the infant girls from the infected mothers, and it's in a and this is in a sexually active people. This is very common, and also it transmitted through the sexual contact, and responsible, and it's an important causative agent for non-gonococcal urethritis, and it's also responsible for chorioamnitis and also proctitis in male, and it's grown on mycoplasma medium supplemented with urea. This is always important to remember, and produces tiny colonies on the concerned medium. And for the diagnosis, the best test is PCR test for the diagnosis of this particular ureaplasma parva. And the treatment, if you see, the azithromycin is useful for both ureaplasma and also Mycoplasma hominis, and doxycycline, of course, useful mainly for Mycoplasma hominis, and to some extent the resistance also was reported for this particular drugs by these organisms. Is a chancroid. The chancroid is again the genital tract infection. The causative agent is the Haemophilus ducreyi, and this is which is a gram-negative coccobacilli, and responsible for STD. The STD, that is sexually transmitted disease, and most common in the developing countries due to their lifestyles. So here you can see the morphology of this bacteria, like the coccobacillary forms. See the virulence factors of this Haemophilus ducreyi, the pili which are present on their cell wall, like these are pili, very small surface appendages. This pili, with this pili they can get attached to the epithelial cells of the genital tract, and then once they establish their infection, the outer membrane protein of this gram-negative bacilli is responsible for severe inflammation. It's responsible for severe inflammation. And another thing is lipo-oligosaccharide or LPS acts as an endotoxin, and all the endotoxic activities will be produced by the infection. And another one is the IgA protease enzyme is produced by the bacteria. This IgA, these are the antibodies, usually the linings of the lining of the mucosal surfaces always protected by these IgA antibodies. So once the IgA proteases are produced, and these proteases acts on the IgA and cause for the destruction of damage to the IgA, so the mucosal surfaces may not be protected. They may not be protected from this particular bacteria. This is how the protease, IgA protease, acts as a virulence factor. Haemophilus ducreyi produces an important disease, chancroid, otherwise called soft chancre. You have to remember here one more chancre, that is hard chancre. This is hard chancre. This hard chancre produced by the Treponema pallidum. It produced by Treponema pallidum, which is a spirochete. But this is soft chancre, which is produced by Haemophilus ducreyi. But there are certain differences are there between the hard chancre and soft chancre. Hard chancre is a painless lesion. This is painless and indurated lesion, but here highly painful and non-indurated bleeding ulcer with a severe inguinal lymphadenopathy. We can easily identify that. To remember this Haemophilus ducreyi, we can say one important sentence like this: you do cry with ducrei. That means always they are very much painful. People always will cry with this particular bacterial infection. So that is the area where you can see the lesions among the infected individuals. This is in case of female and this is in case of male. And here you can see the severe enlargement of inguinal lymph nodes among the infected individuals. The lab diagnosis, the swab or exudate has to be collected from the edge of an ulcer, and also the aspirates from the lymph nodes can be collected. And culture, it's a difficult to isolate because they requires the factor 10, otherwise called hemin. This hemin is required for the growth of this hemophilus organisms. So requires two important factors. One is factor the factor 10, and another one is factor 4. These two are factor 5. The factor 5, these are the two important factors required. One is NADP, that is factor 5 is NADP, and factor 10 is hemin. This hemin is required for the growth of this bacterium. So in the selective medium, where we have to use the chocolate agar with 1% isovitalex and vancomycin. These two ingredients should be there in the chocolate agar to grow this organism in the presence of factor 10 to see the growth. See, the Muller-Hinton agar is also a suitable medium at 35 degrees centigrade in the presence of 10% carbon dioxide. The growth is in 2 to 8 days. Okay, here on the culture plate, if you keep the disc, this factor this is factor 10 and this is factor 5. This is factor 10 and this is factor 10. So you can see the growth. See, this is the growth, a brown colored one, no, that is the growth. You can see the growth here, but you can't see the growth around the factor 5. That means it won't require factor 5 to grow. It requires only factor 10 to grow on the medium. This is actually the Muller-Hinton agar. This plate is Muller-Hinton agar medium. And on gram staining, the morphology is gram negative cocobacilli with bipolar staining. On both ends, you can see the more staining and arranged like a school of fish, like a stream of fish, a school of fish in a particular row like thing they arranged. And the drugs of choices are the sulfonamides, and tetracyclines can be used as drug of choice to treat these conditions. This is the genital herpes. Of course, you might have learned much about this herpes viruses while discussing about the skin infections in the form of herpes simplex viral infections. So on that particular system, you might have learned about it. Anyhow, the remaining a small part of the herpes simplex virus 2, which is responsible for genital herpes. So it belongs to the herpes viridae family, which is in a big family of DNA viruses. The name is derived from a Greek word herpene because the lesions are having a property to creep or crawl from the site of origin. And these viruses are having two important properties. One is latency. Once it enters into the body, these viruses will maintain their viability in the regional ganglion, regional sensory ganglion, and responsible for reactivation whenever the possibility comes for them, and results in relapse of the disease. So one single infection is responsible for to see the disease in many episodes. So these viruses are spherical shaped and icosahedron capsule, and these are all enveloped viruses. Here you can see the envelope of this virus, enveloped viruses with lipoprotein, and this genome consists of double-stranded DNA. The genome consists of double-stranded DNA, these viruses. Genesis, the infected or carrier. infected or carrier state. The person who is infected or a person who is in carrier state, those individuals act as reservoirs are for the source of infection from the human genital mucosa. And this transmission is always possible either by sexual contact or by means of auto-infection. And the infecting sites are mainly the mucous membranes and cutaneous and mucocutaneous junctions of the genital area, and also the mucocutaneous junctions of the lips also sometimes possible. And then these lesions are very much painful and tiny lesions. Here you can see very tiny vesicular lesions and on both sides of the body present, which are multiple in nature, and fever and local lymphadenopathy also present. This HSV2 mainly maintains the latency in the sacral nerve ganglion, which leads to sacral radiculopathy, finally responsible for urinary retention, especially in case of females. This is a very important problem with the sacral radiculopathy. Here you can see the vesicular lesions around the anus. You can see around the anus, you can see this kind of lesions, and also here in the shaft of the penis, you can see the lesions here. Here the shaft of the penis, the vesicular lesions, and labial herpes. See, these are all the ulcers. These are all the ulcers on the labia. On the labia major, you can see this. See, these are all the ulcers which you can see in this particular labial herpes. So, like this, the lesions are produced in the genital herpes. Neonatal herpes, this most common cause is HSV2, and mortality is around 65% without proper treatment and care. The transmission is possible from the uterus. In utero, that means, that when the baby is in uterus, the transmission is possible from the infected mother, and infected birth canal also infective during the birth. So the person or mother who is suffering with this HSV2 infection has to be subjected for cesarean section, but not for the normal delivery. And this neonatal herpes presents either in the form of local lesions in the skin, eye and mouth. Here you can see the mouth lesions in the mouth, and various lesions are seen in the skin, and even eyes also involved. See eyes how badly affected in this particular case. And systemic form also seen in the form of encephalitis. Directly this may present in the form of encephalitis in neonates, among the neonates, but whereas in case of adults, this encephalitis is not primary. Most of the times this encephalitis is secondary to this herpes simplex viral infections. The scrapings has to be collected from the vesicular lesion, and then you have to subject for GMSA stain. In the GMSA stain or right stain, you can see the multinucleated giant cells. See this multinucleated giant cells, and many nuclei are seen. Multinucleated giant cells are seen with the faceted nuclei. See the face like this, the faceted nuclei. These are all faceted nuclei with the marginal chromatin, where you can see the chromatin in the marginal region, and these cells are known as Jang cells. It's known as Jang cells, and of course very simply also we can stain these scrapings from the vesicular lesion by using toluidine blue. In the toluidine blue, this is actual appearance. What we are seeing here is the toluidine blue staining appearance, but in the GMSA stain you can see the different colors, not only blue, you can see the different colors of the cells. But whatever it is, these cells or these infected cells are known as Jang cells. And culture, for the culture we use this HeLa cell line cultures or Hep2 cell line cultures, and cytopathic effects are seen. They are fast growers, so cytopathic effects are seen within 2 to 4 days. And the growth is seen in the form of Cowdery type A intranuclear inclusion bodies, otherwise called Lipschultz bodies. And here the infected cells, see this is the entire thing is a cell, infected cell. The ballooning degeneration of the cell you can see here, and where the margination of the chromatin, see, this is the margination of the chromatin, the margination of the chromatin, and inside the nucleus you can see, these are all the inclusion bodies. These are all the inclusion bodies, the violet colored all inclusion bodies which are present intranuclearly. And if you allow these organisms or viruses to grow on the chorioallantoic membrane, that's the chorioallantoic membrane of the embryonated egg, then you can see a small white shiny non-necrotic pox. This small white and shiny non-necrotic pox. This area is a normal area of the chorioallantoic membrane, but this area you can see the growth of this particular virus in the form of pox. They produces non-necrotic pox. But which viruses produces necrotic pox? The pox viruses. Especially the smallpox virus. The smallpox viruses produces necrotic pox on chorioallantoic membrane. There is a difference between herpes viruses and the pox viruses while they are growing on the chorioallantoic membrane. Almost both colony size almost same, but in case of smallpox virus they produces necrotic pox, whereas herpes virus produces non-necrotic pox. Antigen detection by using direct immunofluorescence technique, also another mode of diagnosis. Here these are all the infected cells, these are all the viral cultures, and here you have to use all the viral cell line cultures which are infected with this virus. Have to be treated with the monoclonal antibodies conjugated with the fluorescent dye. If these infected cells are having this particular viral antigens, then you can see the masses like this. So this is the combination of viral antigen with the monoclonal antibodies conjugated with fluorescent dye. And antibody detection also possible by means of IgM and IgG antibody estimation, either by means of ELISA or by means of indirect immunofluorescent assay. And HSV DNA detection, of course this is an ultimate test for confirmation of this herpes simplex virus 2 by means of DNA detection. Treatment for the mucocutaneous infections, we have to go for acyclovir and famciclovir, and if the acyclovir is resistant, which is possible most of the times in genital infections produced by herpes simplex virus 2 and also among the immunocompromised individuals, then we have to use foscarnet. Foscarnet is the drug of choice for acyclovir resistant cases. Is about the Mycoplasma species which are responsible for respiratory tract infection and also genitourinary tract infections, and also the Haemophilus ducreyi responsible for chancroid or soft chancre, and also genital herpes or herpes simplex virus 2. So you learn, because these are all very important topics for theory. And also the majority of the times, or most of the times, you can see clinically also these cases. So thank you very much. Happy learning.